right. Hey, welcome everyone. Thank you for coming. I am Neil Scarborough, General Manager of Marketplace. We want to welcome you. Obviously, we have a big event, our health and wealth discussion. This idea came from y'all, so hopefully you'll appreciate the content because we didn't just come up with some idea on our own. We asked our investors and our members what they would like to talk about. And so we hope to answer a few uncomfortable questions today, and maybe we'll make ourselves smarter about why the costs of healthcare is such a problem for everybody. It doesn't matter who you are, it's the thing we're all worried about, right? So we'll put it more simply as we have it up here on the board, right? Health and wealth, why Americans are drowning in medical debt. So in a short while, we're gonna bring together some experts to discuss the business of US healthcare. It's going to be hosted by none other than David Brancaccio, the mellifluous voice of the Marketplace Morning Report. So we have our experts, we have our host, but we're probably more excited the fact that you're here because this is your panel. People joining us online, welcome. People joining us in the Kling Center here, we appreciate you as well. And we're also glad because we know who you are. You're Marketplace investors. Your NPR members. And so for those of you who don't know, we're cousins, Marketplace and NPR. We're both owned by American Public Media, which is the proud owner of this big building here. And so we work together, we collaborate often on bringing you the journalism that you consider essential, and that's why we hope you listen to us every day. And also, we're grateful because we can't do any of this stuff without you and your contributions. And so we just want to make take the time to let you know how much we appreciate that. Like everything in public media, every day in public media, we have to begin by thanking you. So we can't do this event without thanking you for your contributions. So you can give yourself a hand because we really appreciate you. And it's how we make a difference with the journalism and how we cover business and how we cover Minnesota. So a little bit about Marketplace, right? So we are, no business franchise in media is listened to or seen by more people than Marketplace in a month. Very few people know that. And our mission is to educate all Americans about the economy. And we say all Americans, we mean all Americans. Underrepresented Americans, people who are on the margins, and then everybody who has a household income and needs to have the economy distilled for them, right? So that's our mission. Our belief is that information begets empowerment and begets equity. So we're here trying to solve problems for folks, and tonight it's going to be about healthcare, right? So anyway, while we all try to make our mission to help the Americans understand the economy, and we hope that Americans rely on us to break that down in Marketplace. At Marketplace, we rely on David Brancaccio, because David Brancaccio is really responsible for two things that he does every day, which is advancing our mission, which I just explained to you, and also preserving our voice, right? We represent the voice of everybody in here, and David has done that for us for so long. In fact, he's done it for 35 years, because when we started in 1989, David was one of our correspondents. Then he took off to London and covered Europe for us. Then he came back and hosted the afternoon show for 10 years. Then we lost him to public TV, God forbid, but it was still public media, so go David. And then he came back and he's been hosting the morning show that you all have come to love for 14 years now? Yep, so anyway, I'm gonna not stand up here and blaze in this hot jacket. I'm going to hand it over to, as we say, the mellifluous tones of David Brancaccio. So he's going to come out here and cue you all up, but we just want to make sure that, like I said, you understand that we are in this together, Minnesota Public Radio and Marketplace, and both of those organizations are nothing without you. So we'll let David take it away and get you guys stimulated about a big problem for all of us, health and wealth. So without much further ado, David the Brancaccio.
Hello. Just want to say thank you for rolling out the nice temperatures for my latest visit to Minnesota. What was it, 17 this morning? Come on. Although, actually, I'm thankful because it's a lot better than the last time I came to visit your estate. Of course, that was outside Grand Marais off the Gunflint Trail in Boundary Waters. 31 below first night. So when I looked at the 17 on my phone this morning, I'm like, all right, could have been worse. You are a hardy folk. Look at you. We business reporters, we focus on a lot of things. We focus on assets. And this is a definition of that asset known as social capital. People who come out of their living rooms on a winter evening to come together, to learn and to think about making your community a better place. So thank you for that. This will shock you, because I'm told I look no older than 33, but you heard from Neil, I'm 35 now. And yes, this is the windowless blockhouse that Marketplace was in under the Harbor Freeway near the DMV, where we would welcome ex-presidents, current Treasury secretaries, and CEOs, big and small, and early Marketplace crews. The guy with brown hair. Oh, the dude on assignment covering an oil spill. Who's that? John Barth, the legendary early producer of Marketplace Afternoon Show with me. We went to the middle of Middle America to explore Does Globalization Matter? Cuba, Missouri. That was a truck stop off Interstate 40 that had a hair salon. And we went live from there for 5 days to talk about globalization. Anyway, it's been a fun ride. We have more for you. We've got some good stuff planned for the election year as well. And later, like maybe when we're mingling, ask me about what looked like me inside a clock face. That's interesting, but I won't go into it now. So our mission is to raise the economic understanding of all Americans, emphasis on all, and that includes understanding and exploring the challenges of paying for health care. Health care policy, I like you, I live it, I experience it, I'm a consumer. I've had, as a freelancer, insurance from my union. I've had employer-sponsored health care. When I was London correspondent, I lived under single payer for the National Health Service in England. My middle kid was born at a NHS hospital. I live it and I cover it. And sometimes it's exalted and inspiring when you learn about medical innovations that save lives. But it's often heartbreaking. I was anchoring a show, and a wonderful producer, Brenda Breslauer, and a wonderful reporter, Maria Hinojosa, did a story about an 8-year-old named Sophie in Tulsa. She had a chronic lung disease requiring lobes of her lungs to be removed with several surgeries. Her middle-class parents couldn't handle the bills. So they went in for counseling. I don't know if it was at the hospital, but a healthcare professional suggested that the parents, Natalie and Stephen, I think their name was, they suggested to the parents that they get divorced so that one of the parents could show up as indigent and be eligible for healthcare programs for lower income people in that state. Now, they loved each other, as our piece showed, and they said, we're not getting divorced. So it was a hard road for them. I did just check with Brenda this morning, and Sophie is in college and doing great. So that was the nicest part of my day. If you listen to Marketplace, you know that we like to do the numbers. We're going to have a series of numbers for you throughout this event. Let me just do a couple quick, and then we're going to get rocking. First, number 17. 17 cents of every dollar of gross domestic product is health care. 90% of Americans have health care coverage. So we're going to talk about that irony. $220 billion outstanding medical debt in America. There are different figures. I chose one credible one, but some of our experts might prefer a different one. 7.6% of Minnesotans carry medical debt. That's not statistically different from the national average, which is 8.6%. In the American South, 20% have medical debt. Almost on the list, 66.5% of personal bankruptcies in America are associated with medical debt. 33 is the last number I'll share at the moment. Top 38 richer countries in the OECD, life expectancy, we are number 33. So outcomes for all the money we're spending are not super fabulous. So I thought to myself, maybe it's a feature of equity, an equity issue. Lower income people, worse health care, worse outcomes. But surely richer people are getting awesome health care and have better outcomes. JAMA study from 2019, comparing the richest 5% counties and the richest 1% counties. So some pretty rich counties in America, with the average health data from some other developed countries. And even the rich counties are worse on a number of measures, not all. Myocardial infarction, maternal mortality, childhood leukemia, a whole bunch of things are not going well. Many factors, but fascinating. I think it's not an editorial or at all a partisan statement to say, in this area we have work to do. So we're going to explore some problems and solutions now. Let us welcome our wonderful first two panelists. Jennifer Schultz, health economist and healthcare policy expert, cost, affordability, access, way more. Medicare, she knows the data, she knows the policy. She's a professor of economics at the University of Minnesota Duluth. Schultz was a state legislator here in Minnesota and chair of the Human Services, Finance, and Long-Term Care and Aging Committee, including during COVID, I think. While her role here is policy analyst, I heard talk of maybe an interest in running for Congress, but that's not fully official yet. Allison Sesso, welcome. As president and CEO of a national nonprofit that will fascinate you if you haven't heard the work. Nonprofit called RIP Medical Debt, charitable organization. The economics of medical debt, those economics are you can buy it for pennies on the dollar, and her organization gets contributions and also can work with states and cities and counties to leverage contributions, and they buy up the debt and get people out from under the mountain. Among their statistics, canceled medical debt worth $10 billion with a B, right?
We're up to almost 13.
13, okay. I had 7 million for people helped, so it is now?
It's almost 8.
All right, so it's going in the right direction. There's a film that came out this winter, Ordinary Angels. I don't know if you saw it, with Hilary Swank, with medical debt tragically featured in the plot, and your organization has connected with that film to, leverage some of what people are affected by when they see the film. So it's all very exciting. We all have superpowers, and there's a person waiting in the wings that we'll invite in a few minutes who actually has a Minnesota superpower. It's the top law enforcement official in this state. The Attorney General will be on the panel in a little while, so stay tuned for that. We also have a wonderful star of NPR News who's going to be here helping me with some of this. Angela Davis is here, so it's really cool. So let's talk, as they say. As you say in Queens, let's talk.
Let's talk.
And I live in New Jersey. We kind of say it almost that way. Allison, we're going to focus on you just for a few minutes, and then we're going to switch to Jennifer. Why did you make this your life's work? Why focus on medical debt? Why is that your piece?
Yeah, so before I came to this role, I actually represented about 200 nonprofits operating in New York City that provide various social services. And, they're Band-Aids to bigger broken systems. And I very much see the organization that I work for doing the same thing. It's an important Band-Aid, though, right? Like there's a broken system. But I see it as two different systems. It's the economic system is broken for people because a lot of the medical debts we relieve are $1,000, $500. I mean, we have higher ones as well, but why don't people have $500 in the first place? That's broken economic system. And then it's also how we finance healthcare. Like both of those systems are broken. And what I liked about the mission of this organization and its uniqueness was that it was focused only on medical debt. So it wasn't on, poverty in general and all these other things. It was very specifically focused on medical debt. And I thought from the vantage point of this position, we could help people and provide this critical Band-Aid to a lot of people because of the economics of how we do our work and how we can leverage $1 and turn it into $100 of relief. But in that process, we could tell the larger story about the fact that we shouldn't, frankly, exist as an institution, which I very much believe in. I do think that we need to fundamentally solve this problem, and in the process, I'm able to tell the story of the individuals. We actually have an anthropologist on our team whose job it is to connect with those whose debt we've relieved, to get a better sense of what it means to live with medical debt and what it means to have it relieved. And through those stories, we're elevating the narrative around medical debt and saying enough is enough. Let's talk about some bigger solutions and really trying to get that larger change. So I think we're both helping people as we wait for policymakers to get these changes to happen, while also putting pressure on those policymakers to do it and make it above other issues at this moment. And so that, to me, was really motivating to take this role.
I'm fascinated that you yourself have said Band-Aid. You didn't say we're the be-all and end-all of the problem. So among the things that you're saying is the debt shouldn't be there in the first place.
Correct. I do not believe the debt should be there in the first place.
And it's not just like you're philosophically opposed to the debt. For instance, in many nonprofit hospitals, people have gotten medical credit cards to pay for their treatment that they can't pay for with cash, even though there should be charitable programs that they would have been eligible for?
Well, and there are charitable programs that a lot of the problems are that there's not a lot of regulation and specifics around the fact that hospitals that are nonprofit hospitals are required to have a charitable approach. There's not a lot. A lot of the details are left up to the hospitals to figure that out, and so there needs to be more focus on how do we make sure people are accessing this? How do we make sure that it's obvious for people to apply for this? I think, and I don't squarely blame the hospitals either. Because to be honest, like they're dealing with revenue cycle and billing, and it's a lot of regulation. And if you talk to the people who are actually in the billing cycles at the hospitals, they are overwhelmed. They are trying to get payments from different insurance companies. There's a bunch of different systems they have to deal with. They also have to deal with the regulations of the governments that are coming their way. And it's a lot to keep up with. And I think that it's hard to create systems and frankly, we don't want hospitals like over investing in their billing systems. We want them investing in the care. So how do we sort of navigate that reality? We want them to invest in the care, not overbilling, but yet we want them to have strong, solid billing approaches that get people the charity care that they need. And so there are solutions to this. There's things like presumptive eligibility, where they can presumptively assume that people are, that's what we do. That's how we don't, there's no application process for what we do. We buy the debt from the hospital. We do a presumptive analysis to see whether or not the people are 400% of poverty or below, or if their debt is 5% or more of their income. And then we buy that debt and we send them letters and let them know we bought their debt. There's absolutely no application process. And so hospitals can do the same thing.
Well, there you go.
And that's what I think should happen at the end of the day.
Jennifer Schultz, from the U, I guess you call it. 90% of people in these United States have health care coverage. So what's with the debt?
Well, even though people have health insurance coverage, they may have very high deductibles. And so they're what we call underinsured, where they have such a high deductible that they may not even have savings to pay for the care that they need. That may prevent them from getting the care that they need. And there's what's called, a surprise billing. There's price gouging. There's care that may have received out of network. The insurance doesn't cover it, so it leads to medical debt. And the fundamental problem is that in the U.S., one of the wealthiest country in the world, that people have to have GoFundMe or bake sales or something to raise money for medical care. It just should not be true, that we should not force people to resort to that. And so the fundamental problem is our high prices. This is why we pay more than twice the amount per person for medical care compared to other wealthy countries. So we have to have healthcare reform that addresses that fundamental problem of high medical prices. And, we've started doing that a little bit, but, healthcare is complicated. I've been working on healthcare reform for 20 years of my academic career and did that as a state legislator. So Minnesota, is a state that has been known for very progressive healthcare reform. I hope we can continue that on that path. But we need things to happen at the federal level. And so it just shouldn't be the case that people are not getting the care they need because they're fearful of that medical debt, of the healthcare costs, even when they have coverage.
And we could do an entire 4-day symposium on why costs are so high. I mean, it starts with the cost of medical school, for instance. Also, the innovations that produce some of the great life-saving drugs are extraordinarily expensive, and the pharmaceutical companies want to recoup what their investment. But I did see a figure. I didn't have it in my list just now. It's $819 billion, and that figure was total profits expected by all for-profit healthcare companies in America by the year 2027, and that will be up 40% from 2022. So that's some of the cost is due to that system.
Yeah, we shouldn't even call it a system because that's not what we have in the U.S.
The hodgepodge,
but we
what should
use
we
that
call it?
word. We use that word. What we have is not a system. It is very complex, but there's a lot of, even at nonprofit hospitals, we pay our CEOs a lot, millions of dollars. So that's part of it. That's not all of the blame. That if we paid them less, we would drastically reduce our, $4.3 trillion spending per year on healthcare. But we just have to pay providers in a different way. And I've been arguing for many years that we have to pay them to show us good health outcomes, since we're not doing well in population health in our country. We need to pay them something like a capitated payments, global budget, so they have an incentive to provide the best care possible to get better health outcomes, and they're not overprescribing, overdiagnosing, overtreating, and we're not wasting resources and not putting money towards things we may not necessarily need.
Thank you.
I
Quick
just wanted to,
comment?
I just wanted to add that there's also, I have to focus a lot on the billing side of things from where I sit, and there are so many vendors that help nonprofit and for-profit hospitals and physicians collect. And all those companies are making a ton of money as well. So there's all these like add-on services that are like for-profit businesses that are making a killing off of the healthcare system right now as well, that I think really needs to be paid attention to.
We have over 200 people watching on Zoom right now. Thank you for joining us at home. And some have sent in some questions, and we're going to bounce them off the panel here. Eric, who's on Zoom, it's an interesting sort of global question here. How can we plan for unexpected medical expenses? I mean, this essentially you have to put away and sock away in a country that many people don't have savings, enough money to pay not just your deductibles, but your out-of-pocket maximums if there are such a thing. I mean, how do you, as a personal finance person trying to be prudent, how do you plan for the unexpected?
Well, to address uncertainty and risk, you buy insurance. This is, what we buy insurance for, is to reduce uncertainty and to smooth consumption over our life cycle. But our insurance products don't have the best coverage today, and they're very, very expensive. So a lot of people forgo buying insurance because it's gotten so expensive because our medical prices are high. But ideally, you would buy insurance coverage for that uncertainty.
Yeah, I would just add that I think what's happening for a lot of people, especially low-income workers, is that decent insurance is out of reach for them. I mean, the premiums are just too high compared to their income, and then they're getting this insurance coverage that has expectations that have very high deductibles that are also that a lot of the debts that we end up relieving at RIP medical debt are actual deductible amounts. It's not that they're uninsured. It's that they're underinsured, to your point. And so that, I think, is one of the biggest things that we have to focus on, the fact that people are underinsured, and they are underinsured because they can't afford the better, more expensive insurance coverage at all. So it's out of reach for people.
Carol, Caryl, is looking for some pointers. Carol's lucky enough to have good medical insurance on paper, but they need tips for getting them, I guess the insurance companies, to actually pay claims for out-of-network coverage. You've looked at the billings. Is there any tricks you've come up with in your own life?
I mean, it's difficult. I think if you're out of network, you're kind of out of luck. That's what ends up happening. And you have to try to negotiate, which we know is problematic also, because we also know that people of color have worse outcomes when they try to negotiate in general in things. And so there's this other racial component to a healthcare system that has almost a built-in expectation of negotiation, which exactly what we have. And the idea that you're going to shop for coverage is just a ridiculous one is on top of that. So unfortunately, I don't have good advice. I mean, I would say stay in network and know what your network is and check in advance as much as you can. Unfortunately, that doesn't work in reality if you end up in an ambulance and unconscious, but do the best you can to,
Jennifer, there's a new federal law that's supposed to stop the surprises.
In 2020, Congress passed, and the president signed the No Surprises Act. So you were not responsible for out-of-network costs if you did not have the choice of provider or of an ambulance service. And this came to light when air ambulances were charging outrageous amounts, hundreds of thousands of dollars in some cases, and you needed to get to a hospital. You couldn't choose the helicopter service or the air service. But right now, this is being litigated, and there are like 5 bad actors in the country, provider groups that are suing and in court to change how this is supposed to be implemented, and it's preventing people from getting reasonable prices for health care, and they're still having to pay that out-of-network care. So we need to make sure that the No Surprises Act is implemented as intended and that the government prevails in these litigation cases. But the other big problem is that hospitals are buying a lot of provider groups, and that is so they can charge hospital prices for outpatient care. And there's a bill that passed the U.S. House with bipartisan support called Lower Costs, More Transparency. This bill needs to pass the Senate. It does not allow hospitals to charge outrageous prices for outpatient care, and that should be applied to all of services that can be provided at an outpatient clinic. So this consolidation, mergers and acquisitions, these are happening at extraordinary rates now. Our healthcare system is so consolidated, and that makes prices even higher. So we have to look at that.
So there's much more of this to come, including with this panel of wonderful experts. But we're going to move in just a moment to the second part. But they have this music they're going to play that's like the hook to make us stop part one. It's such good music. I like it, don't you?